Next, I'd like to call Dr. Nishanth. He'd be speaking about not a clear cornea management techniques in phaco. So Dr. Nishanth is an ardent sports person. He's an adventure lover, adrenaline junkie, I would say. So he enjoys music as well. He's a cataract, cornea, and refractive surgeon at M&I Hospital. Dr. Nishanth.
Thank you. Good evening. I know that this course is in between you and Javed Ali's concert. So just got 3 more amazing talks over here. We all, as a cataract surgeon, I'm sure that we would like to have clear corneas, but what if we are not getting that so clear corneas is what I'm going to talk about. So what do you call a compromised cornea? Any cornea which is unhealthy, the local causes such as degeneration, endothelial diseases, post-refractive surgery, or previously operated eye. And what are the pre-evaluation pearls which are required? Make sure that you document all the corneal pathology either by slit lamp photography or specular microscopy. Take adequate PACI because sometimes, or even ASOCT because they also give a lot more pathologies of the cornea as well. Counseling is very important, like Dr. Ashwati told in her talk about the risk which was involved in compromised corneas, difficulties even during the surgeries because we are not going to have the glow as much as what we expect. And the prognosis and the outcome is also definitely much needed. So epithelial problems can cause problems like post-cataract surgery. You might have a persistent epithelial defect. While hydrating, you will actually realize that you have epithelial ballooning and you might not have a proper clear epithelium. And this all happens in mainly the epithelial basement membrane dystrophies, which might be missed in a normal slit lamp as well. People with Bell's palsy and exposure keratitis is also definite to look out for it because they might have an adequate exposure. Post RK and post PK surgeries, I think Dr. Advait has covered it in his talk. Fuchs dystrophy is one of the most important indication because we actually, the same way the earlier cases we tend to miss. So make sure that the endothelium of every cataract patient is looked at, even just with extra 3 or 5 seconds. Make sure that you look at the endothelium. Herpetic corneas, it's not only the scarring which happens after the post-herpetic conditions, it's also the loss of the corneal nerves and sensations which could cause recurrent epithelial erosions and constant irritation to the patient post-herpetic. So make sure that they also get pre-herpetic, I mean before the cataract surgery, I do start them on IC556 400 milligrams 3 times a day as a dose for about a week or 10 days. For Bell's palsy, you make sure that the ocular surface is treated first. There can be some tarsography which can be done as well, and taping of lid can be done in the night also. Corneal scars depends upon the depth, whether it is leukomatous, macular or full thickness, whether you want to do a combined procedure or whether you want to do the corneal procedure first. I have few surgeries which I have done the corneal procedure, the phaco first, and then there are some procedures where you can do the cornea first. The main thing about doing the phaco is if you are able to get a proper IOL power calculation, I'll say yes, you can go ahead with it. And the need of customized IOLs like toric or aspheric lenses is also based on the corneal topography. So as I've told about all the duct toxicity, make sure that the cornea is, that's one of the main complications is the cornea anesthesia, which can lead to neurotrophic keratitis or infectious keratitis or immune ulcers post cataract surgery. The other consideration is you can also start with scleral tunnel, which is actually very good. Not all clear corneal phacos are perfect, and superficial keratectomy in EBMD diseases, management of pterygium first and then the cataract if at all you have a lot of astigmatism, and avoid premium lenses. Sometimes we have patients nowadays who come saying that not a problem sir, whatever it is I understand, but still put a premium lens. But if you feel that no, this patient will not be happy, never operate for the patient's sake, because I think those days are gone, because the day one they come back saying that I never told you, you only advised this lens. So please, please, please put only multifocal or trifocal or any of those premium lenses if you are satisfied with the ocular surface. Systemic problems, yes, we have to look at them as a whole. We always, I think all the talks say that don't look at only the ocular surface. Look at the patient as a whole from the top to bottom and find out what all that they have been taking as in terms of long-term medications. Endothelial diseases, specular microscopy, very important. Cell count not less than 700 per cubic millimeter. Slit lamp photos, intraoperatively, use abundant visco. The best is the soft shell technique. And even though you are a surgeon who operates within 5 minutes, be it stop and chop or direct chop, after phaco 1 or after a trench, make sure that you can put some more viscoelastic. It is just going to take 5 seconds extra, but I'm sure that's worth benefit for the patient and for you as well. Cold phaco techniques, and not always phaco is the hero. I have a case of SICS which I'll be showing you, where the best thing is after SICS the cornea is still clear. Whether you want to do it combined or alone, it depends upon the endothelial cell loss, because we all know that during phaco there is a cell loss around 6% to 12%. So even if you try to reduce the phaco energy, or you do in the back phaco, or use the phaco and the Ozel technique, you will still have endothelial cell loss, is what we say finally. So counsel the patient that the chance and the need of endothelial surgeries might be required after any phaco surgery with endothelial problems. Combined procedures, yes, it can be PK with ECC IOL or phaco with IOL. I never prefer PK with IOL because it is an open sky technique. I mean, we surgeons are afraid of the complication, which I think Dr. Naga has explained, that the expulsive hemorrhage is there. So as the sooner you close the eye, the better it is. If you're planning for a surgery, I would rather do a phaco IOL or a DSEC, not an ECC with IOL. So these are few pictures thanks to Dr. Sujata Mohan for sharing, and she's done a lot of combined procedures. You are not sure that whether this patient has undergone phaco or a DSEC. So indication for two-step procedures is if they have a severe stromal dystrophy, you have to make sure that the depth of the dystrophy is important. I don't think if there is any endothelial involvement, make sure that you do a PK. Don't do only an anterior DALK and then later on come into recurrence. So post-refractive surgery was dealt in detail by Dr. Advait, who told us that in few years' time, yes, we are going to get a lot of patients who are post-refractive and who demand not cataract surgery but a refractive cataract surgery. So problems in keratoconus is they are not clear. I mean, the astigmatism is not straight, so there are irregular astigmatism, so you're not sure about the toricity. So even in these cases, you can try to stabilize the cone. So we do something called a trek, where we try to make sure that the cornea becomes symmetrical, and then we can decide on whether we want to put a toric or a monofocal lenses. The lid margin is one of the main thing to see, more than the slit lamp. As I told you, it is only the torchlight which gives you a much better benefit. So these are just last video which I've showed. So this is a leukomatous opacity. So I start by doing the rhexis underneath the opacity, because once you start getting that, and then the rhexis is going to be, you can see that because it was a full thickness penetration, even the anterior capsule was also damaged. All my trenching will be at the side. Do not go underneath. Just make sure that you are away from the area of the opacity. Look, my phaco probe is always to the right a bit. It never goes under the area of the scar. And if you have good microscope with good retroillumination, I always use a bimanual technique, because it is something like a third arm. You can always retract the iris, you can always move the eye, and then you can visualize with the area of cortex and you can remove them. This is a case of post-viral scar which was stable for almost 6 months with no recurrence. So the whole surgery, usually I don't do it in this red glow alone, because it gives a good rhexis, but in terms of the nuclear management, I am comfortable with both the red glow and the normal light. Even here you can see that the area of where I am able to find a bit of clear cornea is where my phaco probe is, and don't go underneath the area of the scar. This is where I told you. So this patient had some vision. Almost be wondering why I didn't do the PK first, because the scar was little off the axis, just inferior, and the patient actually felt that he could see something above the scar. So what we did was I just released the adherent glaucoma, and it was a brown to black cataract, and you can see I didn't even try a rhexis. Please don't show your heroic skills. You see what is best for a patient. I just did a can opener technique, and I did a small incision cataract surgery. So outcome, post keratoplasty, plan suture removal before the cataract surgery, and do combined procedures whenever required. Thank you everyone.
Thank you, Dr.